All right, share screen. All right, so we are switching gears. I want to stress that again. We are switching gears now and talking about therapeutic exercise. We are switching gears, we are switching gears, we are switching gears. So we are no longer talking necessarily about the movement of the body, but we're now talking about improving our patient's function through therapeutic exercise. We will take a break, get started on this. We'll take a break in about 20 minutes. So let's get started on this at least, that way we can get started. So, definition of therapeutic exercise. If you ask a patient, they're going to tell you the definition of exercise is pain, torture, workout, and it's unnecessary. Right? I always joke with patients that PT doesn't stand for physical therapy, it stands for pain and torture. Right? What would you define therapeutic exercise as going to be a new clinician? How would you guys define it?
Well, you just said it, improving function.
Yes, right? Using movement to improve function. Really, right? Improving your muscles, right? To get back to normal life. Good. Or to improve your life, right? It may not even have to be to get back to normal life. Maybe, you know, Amanda, you're training for a triathlon. Right? You're not going to just go out and run a triathlon, and if you are, it's going to suck. Just going to warn you, right? But maybe you want to improve and get ready to run a triathlon. Well, you're going to have to do a lot of therapeutic exercise in order to get there. We've done therapeutic. If you've ever gone to the gym, you've done therapeutic exercise, and just you don't call it that, right? You just call it exercising. Some of the key terms we will use in TherEx: balance and postural equilibrium, meaning things being in perfect alignment, straight up and down, and keeping the patient from falling. Cardiopulmonary training and endurance training. Neuromuscular control or coordination. Mobility and flexibility, muscle performance, and overall stability. All of those terms will come into play. Are any of those terms unfamiliar to anyone? Those should be pretty common terms, right? I hope that most of you get them. When we are talking about those, overall, those muscles kind of form a Venn diagram to allow us to have function, right? Our balance, our muscle performance, our cardiopulmonary endurance, our mobility, flexibility, our coordination, our stability all allow us to function. Depending upon what we do, we may have to improve one or the other in order to improve our function. If my balance is off balance, if my balance is off balance. If my balance is out of whack because I have an inner ear infection, my function is going to be decreased, but I may be able to counter this by using more of my muscle performance or more of my mobility to improve my balance. So there's a delicate balance to all of this, where they work in conjunction with each other. But also, if my balance is off, right, if my balance is messed up, my stability is often knocked off. And once my stability is knocked off, it requires more neuromuscular control and coordination to function. So they all tie together in this kind of vicious Venn diagram of stuff going around that helps us do our everyday tasks. Even something as simple as you guys sitting here, listening to me lecture and drone on for these hours, requires function. You don't think about it, but you're all sitting here, most of you upright. You know, right now I'm sitting with one foot on the ground, the other foot folded over it. My balance is off a little bit, so I have to work on more muscular control to keep myself upright. But I'm not actively thinking about it, because if I did, I'd probably fall over. My body's controlling all of that innately in the brain. And when I lean to one side, in my brain, it's like, hey, you're leaning to that side, straighten back up. And I don't have to think about it. Now, what happens if my cognition goes down? I might actually have to think about stuff like that. It may be more difficult for me to function. Types of therapeutic exercise intervention, aerobic conditioning and reconditioning. This is probably, out of all the stuff that we do with patients, this is probably their least favorite. That was good. I missed my mouth. I'd be willing to bet if we asked most of the people in here, aerobic conditioning is the least favorite thing to do at the gym. Would you guys agree with that? Getting on the treadmill, getting on the bike. Yeah, that's usually our least favorite. And why is that? There's a lot of reasons for that. It's just, you know, it's hard, right? Stephanie's like, I love that. All right, some people do. I hate cardio. Okay, liars.
What is that?
What is cardio? I love it, right? But cardio is as important to our physical health as maybe it's just as much doing lifting and stuff like that. Muscle performance exercises, right? We can train for muscle strength, we can train for power, and we can train for endurance. Stretching. I'd be willing to bet this is probably one we most skip because we really should be stretching about as much as we're strengthening, but we don't do that. A lot of times, how often do you see people after they've worked out in the gym go over to the corner and stretch? Not very often. Neuromuscular control is another one. That's one we don't train in the gym very often. But let's say that you are a hockey player or a soccer player. Is there a lot of neuromuscular control in playing professional sports?
Yeah.
In certain positions, I would say yes. Like I played fullback when I was in high school. I wouldn't say there was a lot of neuromuscular control in that. Run forward 5 yards, hit somebody. Right? But for a wide receiver, there's a ton of neuromuscular control to catch a ball that's traveling at maybe 80 miles an hour, 40 yards downfield while turning and jumping. That's a lot of neuromuscular control. Goalie, yeah, right? Some of the best goalies, like, you know, I'm a Coyotes fan, so watching some of the goalies play for the Coyotes are probably that's the only people I can watch on the team that don't embarrass me. But watching some of the, especially in hockey, watching them actually block goals and some of the control they have. Yeah, I forget the Knights. Coyotes were the original desert hockey team. I don't want to hear it. But watching the control of some of those, you know, and put something, so if you get a rookie fresh, yeah, Hope Leonard, all right? That's actually a really good, that's what I was going to actually use that as an example, Joe. So that's a great idea. Look at the difference, if you do watch the Golden Knights, watch the difference between somebody like Leonard in goal versus Fleury in goal. If you actually watch them, they play goalie very differently, right? Because, and for those of you like that are, I don't care about hockey, that's fine. But Leonard is a really big guy. Like, he's pretty massive, right? He plays goal mainly by blocking the goal. Where Fleury is not quite as big, and he has to play a lot more on control. So it's really interesting to watch that, and you can see some of that. I've watched some professional soccer. You know, what we call soccer, what the rest of the world calls football. It always amazes me that the guys that play professional football, soccer, the goalies are usually pretty small, right? When you think over here in the United States, the guys that play goal over here are usually the big hulking like goalies that would play in hockey. But over there, man, their goalies are small and quick. They have a lot more neuromuscular control maybe than we have. It's also why oftentimes we don't go very far in world soccer games. I'm just saying. Postural control, body mechanics, and stabilization. We need those for most of the stuff we do. Balance exercises and agility training. This is important, especially for your patients, especially patients that fall a lot. Relaxation. I'd say this is one we do the least amount, probably as well, almost as like aerobic and stretching. Our life does not revolve around relaxation anymore. We live in a world of just being freaked out constantly. Relaxation goes along with breathing and ventilating muscle training. We will actually practice teaching patients how to breathe properly. It's not very exciting, but for the patients, it can save their lives. And then we get to the task-specific training. I can have people do long arc quads and leg press machine all I want. But if their goal is to kick a kickball, what I really need to get them doing is kicking a kickball and practicing task-specific training. If you want to get good at anything, you have to do that thing, right? You know, if you wanted to get good at paintball, you wouldn't go play football. Is there some carryover? Sure. There's some carryover in the activity, right? There's some cardio training, stuff like that. But if you want to get good at something, you have to do what you're getting good at. For you guys, if you want to get good at being a physical therapist assistant, you are right now currently in class to be a physical therapist assistant. You are doing task-specific functional training. Along with doing exercise, there has to come safety. And one of my phrases that I use is ABGB. Does anyone know what ABGB stands for? Always be gait belting patients. You should always, hold on here, let me grab it. It's sad that I have 3 of these within like reaching distance. Always have a gait belt on your patient. Patients don't like these. They feel uncomfortable. They don't like them. I always tell my patients, this is not for your protection. This is for my own protection. It's really for their protection. I guarantee if you do not use a gait belt, and we will get you a gait belt. Isn't that nice of us? Aww. Always be great too. Yeah, that's a good idea. We will get you guys a gait belt to use. Put it on every patient. I have clinicians that come, or students that come back and say, my clinic didn't use gait belts. Too bad, use them. The reason I say that is the patient that you take your eye off for 1 second that doesn't have a gait belt on them is going to be the patient that does what?
Oh.
False. True story. One of the clinics I worked at here in town, we had a young girl that we had been seeing at the clinic since she was 5 years old. She had spastic cerebral palsy. She could walk, she could do most exercises, but she had really tight calves and sometimes her muscles twitched and stuff like that. And in that clinic, the therapist, who I won't even name and I won't talk about the clinic, used text to treat kids. And you will find really quickly that is my pet peeve. That is by far the biggest pet peeve I have. No tech should ever be touching a special needs pediatric patient. You are not licensed. You should not be doing that. But he had this tech working with that special needs patient. She was doing slant board basketball. So she was standing on a slant board into basically high dorsiflexion and shooting a basketball. And the tech did not have a gait belt on her. Can you guess what happened? She lost her balance, fell straight forward. What do kids do when they fall forward?
Reach out.
Reach out. And she ended up fracturing both scaphoids and a 90-degree fracture in both radiuses. Bone popped through skin. Who's at fault?
The PT probably.
100%. Who do you think the PT blamed?
The PTA.
It was a tech, actually. It wasn't even a PTA. That's a big thing, right? So the PT instantly fired the tech. On site, you're fired. Get out of here. In reality, it's his fault. Truth. Right? It is. And Sydney's right, lawsuit waiting to happen, right? Just by putting this on, could that have possibly saved the kid from fracturing their arms? Yeah. right? She may have still fallen, but there's a good chance you could get a hold of the gait belt and keep her from face planting, right? The other thing this will help is this will provide you with safety as well. Because sometimes patients are going to fall on you. And if you don't have something to hold on to, you get awkward positioning. And then you save the patient and end up doing what to yourself?
Falling.
Yeah, falling yourself or hurting yourself, right? It's the truth. Always put a gait belt on your patient. Honestly, most of the times that I'm treating a patient, I have a gait belt on the patient and I have a gait belt on myself. And why do I have a gait belt on myself? Because I tell the patient if they feel they're afraid of falling, they can grab onto my gait belt. Because that keeps them from doing something like grabbing my neck. We'll talk about how to use this, but ABGB, always be gait belting patients. And always be great too, but that's beside the point. Functional qualifications. About 5 more minutes, we'll take a break. Why do we need to classify function, dysfunction, and disability? Why do you think we need to qualify this or classify? Could we get away with not ever qualifying anyone for disability?
I was going to say like insurance purposes.
Insurance purposes. That's the main reason here in the United States we do. You're 100% right. In the United States, it's insurance purposes, right? You know, we use all kinds of different models. We used to use the NAGI model for classifying disability, right? And we'll talk about this. But do you think the concept of disability varies between the United States and the rest of the world?
Yes.
Yeah.
Yeah, does a lot, right? You know, I've seen patients when I've done, what do you call them, mission trips to like Haiti and stuff like that, where they've walked 20 miles missing a foot to come get seen for, you know, low back pain or something like that. And here in the United States, we could get somebody that goes on disability because their pinky is broken or something. I'm not saying that's not a disability. I'm just saying in the United States, we have definite disability-itis. Right? And you can know that by the television, right? How many times when you're watching television, if you're watching in the middle of the day, does Glenn Lerner pop up on your TV telling you just call him now at 877-1500 about your disability claim? Right? I don't know. I think we have a little bit of disability-itis. The other thing is once we have somebody that's disabled, do we try to get them better? Not really. I don't think we do, at least not in the United States as much as we could, right? In other countries, if you're disabled from your current job, the state pays you to learn a new job. Why would the state pay you to learn a new job?
So you're functional to the society?
Yeah, right? Because they know everyone contributes to society. If they just pay you for disability and have you sitting at home, you're not helping society really, right? So, you know, if you've got somebody that was a box picker at Amazon or something in some other country, and suddenly they lose their hand in a terrible accident, well, maybe we're going to train them now to do something else at the same company and still be a functional member of the team. We do that a little bit here, but not as much as we should. When I broke my neck, that was one of the first things that I went to see, not workers' comp, what's the term I'm looking for? Vocational rehab. And vocational rehab's like, well, are you looking to go on full disability? I'm like, no. Why would I want to go on full disability? I mean, granted, I could go on full disability and sit at home and do nothing, but no, I still want to work. But I'm wondering how many people at that point, when they get asked that question, just say, yeah, the company does look through it. That's we could have a whole long conversation on that, John. We could have a whole long conversation on that. John says, the company's just looking to replace you. You're 100% right. Right? We're disposable in the United States. We just are. I don't know. It's a little different worldview. So Did you guys talk about the Nagy disablement model in PT 110 back way intro to PT? You remember a little bit about that?
Yeah, I think we kind of like touched base on that on
Yeah.
other class too.
Yeah, good news is you don't have to know a lot about it. The only thing you have to know about the Nagy model is it was replaced with the ICF. They've taken out a lot of the questions on the Nagy model. So small round of applause for that, right? You do have to know the ICF model. And that is what we're going to get into right after break. So I'm going to stop sharing here. Let's take a break. We're going to come back at recording, and we are back from break. So the last thing we had finished off with is talking about the ICF, or the International Classification of Function, versus Nagy, which was the International Classification of Disability. So the ICF takes things, instead of looking at it from the disability standpoint, and looks at what the patient can and can't do. Why this is important for you guys, because you have to understand the difference between a problem with the body function, a body system, and limitations. So we're going to look at this from a shoulder perspective as we go down through this. I'm going to read them, and then we're going to talk about it from a perspective of a shoulder injury. So impairments of body function is a problem with the system or a problem with an actual systems of the body. So something like neuromuscular system, musculoskeletal system, cardiovascular system, stuff like that. Can also include psychological function. Impairments in body structures are problems with the anatomical features of the body, such as the muscle itself, the bones themselves, stuff like that. The activity limitations are what they are not able to do because of their problem. Participation restrictions are because they can't do X activity, what is there, are they limited to in their personal life? So I'm going to use an example here. So you have 85-year-old Bob that comes in, and Bob has a frozen shoulder. What could be a body function or system that would be problematic? So he's limited to 85 degrees shoulder flexion.
Muscular?
Muscular, okay? Could be muscular. Could be skeletal too, right? Could be the skeletal system. Could it be neuromuscular? Could it be nervous system?
Yeah.
Yeah.
Yes.
So that would be the impairment. We'd have to determine, the PT itself would have to determine when they're looking at the ICF, is this a problem with the musculoskeletal? Is this a problem with the neuromuscular? Is it a problem with cardiovascular? Because maybe they're not getting enough blood to their arm, right? Most chances it's a combination of a lot of systems, right? It's probably neuromuscular and musculoskeletal. So they're going to look at them both. So the structure that is impaired would be my shoulder joint. Does that make sense? Because I can't lift up here, my shoulder joint is my structure impaired. Because my shoulder joint is impaired, what kind of stuff may I not be able to do?
Flexion, shoulder flexion.
Okay, flexion, right? Yeah, now you're getting, that's along the structure, but like actually tasks that I might do during the day.
Like washing your hair?
Good, washing my hair. So because my neuromuscular system is messed up, and because the shoulder is messed up, I can't wash my hair. That's the activity limitation. Getting dressed, good. And I can't get dressed. I'm sloppily dressed. I'm only putting on, I don't know, t-shirt. Right, limited ADLs, exactly. My ADLs fall under that activity limitation, activities of daily living. Now, because I don't wash my hair and I can't put on a shirt overhead, what kind of stuff would that limit me to doing in my real life?
Go out.
Going, yeah.
Get out.
Driving?
Public.
Yeah, going in public, driving, right? Maybe I'm no longer going to bingo on Friday nights. So now that not going to bingo would be my participation restriction. Do you see how those all kind of play in together? Everything leads back to depression. Exactly, Joe. But let's take that as an example. That's actually really good, Joe. So now, because I have a problem with my neuromuscular system, right, that is limiting the structure of my shoulder, that is limiting me from washing my hair, that is stopping me from going out to play bingo, I now get depressed. So now I have a problem with another body function and system, right? My neurosystems now. Messed up. Because that's messed up, my weight goes up. So my body structure gets depressed. I get sedentary, right? Good. Because I'm getting sedentary, now I don't shower as much as I used to. Because it takes so much energy just to get out of my chair and go shower. Now because I don't shower, now I'm not going to family events anymore. Right, it's that real negative feedback loop. Exactly. Do you see how that kind of plays into effect here? So our goal is to give the patient an off-ramp. Right, look, I know you've been on this circular cycle. We need to get you an off-ramp out of here so that you can get back to doing the stuff you would like to do. So a PT would write on their eval that the patient has a neuromuscular problem with their shoulder structure, right, that is limiting them to 45 degrees or 85 degrees of shoulder flexion, impairing with their activities of daily living, such as washing their hair, dressing themselves, bathing themselves, and is preventing them from obtaining their normal daily life of working as a mailman. That would be looking at an ICF look of that patient. Does that help clarify the ICF a little bit and make it a little bit more real?
Yes.
Cool, thank you. Now, the ICF also does look into contextual factors. And what contextual factors are things that are backgrounds of individuals' life that affect their overall function, right? Environmental factors, right? So with their physical, social, and attitudinal environment which patients conduct their lives, right? Maybe they have a history of depression, like Joe said, right? And, you know, in my family, we are the history of depression, right? But truly, maybe they have a history of depression and have a history of other problems. That would be an environmental factor, right? Or actually, it'd be a personal factor now I think about it. Environmental factor, maybe Joe's shower is one of those really, really high shower heads. And all of the stuff for his shampoo and stuff are way up. Now he can't reach up to grab his shampoo, and that's why he's not showering. So we may have to adjust some of the environmental factors. Maybe now Joe's stuck in a wheelchair, and he can't get in his house because there's 2 steps to get in the house. That wouldn't be an environmental barrier, and we'd have to adjust that. Personal factors would be stuff that we can't adjust, right? His age. Maybe his shoulder's just broken down because he's 90 years old. And he spent his whole life as a mailman, and that shoulder just has wear and tear on it, right? Your car. Can you drive a car off the car lot and just keep driving and it never needs any repairs? That would be awesome, wouldn't it? Like the Car for Life program. Unless it gets in an accident, you never have to do anything else with it. But we know the tires wear out, the brakes wear out. I'm looking at that right now with my truck. My tires are getting a little long in the tooth. And I don't know what you guys know about truck tires, but I have 22-inch rims on my truck, and 22-inch tires are not cheap. So I'm going to have to replace them soon, right? That would be a personal factor. Because I don't want to. Coping skills can be a problem there. Character, affect, cultural. Yeah, replacing brake. You know, I don't mind replacing brakes myself. I just can't do it in my parking lot here. Oh no, you have a broken transmission. Oh no, that's not good. Would socioeconomic factors have to play into this as well?
Definitely.
Yeah, let's say Joe is, how about let's change it? So we have 2 different Joes. Both of them have the same problem. Both of them are having frozen shoulder. Joe 1 is Jeff Bezos's dad. Right? And then Joe 2 lives, you know, in one of the trailer parks on the east side of town. You know, he's done a menial job, right? Rich Joe versus regular Joe, right? Would they possibly both have different outcomes?
Definitely.
Mm-hmm. Yeah, one of my favorite examples of that is I had a patient who was 28 years old back in Pennsylvania who was on, he's on Medicare or Medicaid because he has some social depression issues and stuff like that. Ended up tearing his ACL. And he came for therapy. His insurance gave him 9 visits of therapy. The same day he tore his ACL, Adrian Peterson tore his ACL in the NFL.
Dr. James Andrews, I think.
What's that?
Was it Dr. James Andrews that fixed his knee? Like the best
Something like
doctor?
that, yeah. Right? So the difference between them, my guy never really got better because he only got 9 visits. Adrian Peterson moved a physical therapist into his house with him. And he got physical therapy 8 hours a day. Different world, right? So socioeconomic factors definitely play into it. What about race? And I don't want to make this into a total race thing, but could race play into this as well?
It could.
Yeah. Is there a distrust between certain races in the medical community? I mentioned the Tuskegee experiments.
Yeah.
Right? Definitely. And there's other things. I mean, if you even look at COVID, if a African-American male and a Caucasian male went into the hospital, they get different care. Henrietta Lacks, yeah, exactly, right? So we know these things happen. And why, we don't could get into social reason why that is, but that's just kind of sad thing. In the United States, we try to treat conditions. In the world, they try to prevent conditions. Which one of those do you think ends up with a healthier population?
Preventative.
Preventative. Yeah. Like when I worked in Denmark, everyone in Denmark got 2 weeks of physical therapy a year. They had to go. That was part of their health plan. They had to go for 2 weeks of physical therapy a year, even if they didn't need it. Now, if they needed it, they got more, okay? But they had 2 weeks to go in for what they called the physical therapy checkup. And, they came in, we checked all of their joints. We talked about balance. We talked about diet. And amazingly enough, if you ever lived in a country like the Scandinavian countries or Europe, most of their population is healthier. Could we prevent a lot of our disability here?
Yeah.
Yeah. I'm looking at Appalachia where I come from. We could prevent disability really easily by never flooding it with opiates. There's a pharmacy in a town in West Virginia. I forget the name of the town in West Virginia is. The population is 700. That pharmacy filled 4.2 million opiates. Prevention is bad for profit, so you're 100% right. But prevention is bad for short-term profits. Prevention is great for long-term profits. Right? Why do all the why does a lot of the companies in Europe last forever? Right? Whereas here, a company rises and a company falls, except for like McDonald's and Amazon, which we'll never get rid of. What are some risk factors that would predispose you maybe to becoming disabled? What do you think that could set you up for disability?
I often see things about diabetes and obesity.
Yeah, right? Obesity, definitely. If you look at smoking, right? If you could, I bet if we could stop obesity and stop smoking in the United States, I bet we could cut I'm just going to come up with a number off the top of my head. I bet we could cut disability by at least 40 to 45%. Because those are two of our leading factors to this. Now, good news is smoking is on the decline. I will say that, right? If you grew up when I grew up, when there was ashtrays everywhere, vaping is rising. We won't give into that. But yeah, so some of that stuff, the age, right? Our age is going to predispose us for disability. We're eventually all going to break down. It's just the way it is. I feel it every day. Every day I wake up and something new aches. I'm like, oh, hey, I didn't know about you, Piriformis. How are you doing today? But as we get older, our body just kind of breaks down. We're designed that way. Right, there's one right there. Danielle says, cheaper unhealthy food versus pricey healthy food. I always heard the best way to shop in the grocery store is by shopping on the perimeter of the grocery store. It's also the most expensive way. Right, it's really hard to eat healthy on a low budget. Right? It's really easy to pick up Hamburger Helper and stuff like that, and it's really cheap to pick up that stuff and time effective, right? If you got 5 kids and you have 20 minutes to cook dinner for them because you have to be to your second job, those things are kind of set up. So yeah, there are definitely risk factors that will predispose us for it. So when we get patients, we have clinical decision making that comes into play, right? The evidence-based kind of triad there is looking at what we learned, what we know. Vegetables are cheaper than they think. Yeah, you're correct. I'm not going to say they're not, Bianca, but if you overall eat healthy, it does typically have a higher cost factor, especially if you're eating stuff like organic. And they don't last as long, right? That's the other problem, right? And you're exactly right. I can put a box of Hamburger Helper in my closet and it will be there after I'm dead. And probably still be cookable, right? Yeah, I mean, I've got temporary foods that I keep MREs and stuff like that will outlast me in this world. But anyway, when we look at how to treat a patient, we have to use a couple things. We have to use clinical decision making. We have to look at what we've done in the past. But if we only look at what we've done in the past, we'll never evolve as a profession. So we also have to look at evidence-based practice. But if you actually talk to a clinician in the real world and ask them how often they read research, what do you think they say?
Just for continuing education.
Yeah, just for continuing education. You're exactly right. Because they're not given time to read research. Right? We don't know, how to, honestly, you guys will come out and give some of these clinicians new ways of treating patients that they've never seen. Just because, we're, as educators, forced to read the current education, right? Whereas they don't get time to do it. So when we manage a patient, the first thing they do is they come in and they have to give us a history, right? An exam. They give a history, systems review, tests and measures. The PT writes the evaluation, gives us our diagnosis, gives us our diagnostic categories and what we can treat the patient with. From then on, they're passed to us, right? And then we manage them. They're going to be given a plan of care, and a prognosis is, what do we want to do with this patient? But we have to set some goals. And when we're setting goals, we have to have the patient involved in that. They can't be not involved. If I set a goal for a patient to walk a mile, and they're like, I've never walked a mile in my life, do you think they're going to walk a mile? No. We have to set reasonable and attainable goals that the patient buys into. We're then going to use interventions to provide them stuff, modalities, exercises, coordination stuff, right? We're going to give them instruction. And then we're going to measure the outcomes. The outcomes are what's going to benchmark us and provide us with them coming back to us, right? If they don't get better, they're going to stop coming back to us. But it's interesting here. What do you think the number one reason a patient returns to the same physical therapy clinic is?
It's the only one that takes their insurance?
Could be, okay. I didn't think about that one. That's actually not a bad one. But when you ask the patients, the number one reason they say is because the clinician was nice to me. They may not have gotten better, but because they like their clinician, they come back. I have mixed feelings on that. I always joke that my patients want to get better so they can get away from me. But I will say that patients have followed me. I've gone clinic to clinic to clinic and taken patients with me and whole families with me to other clinics because they liked the way I treated them. Maybe I treated them with respect when they didn't get it in another clinic, right? So, I don't know. And then we will be involved in the discharge planning. We'll talk a little bit more about that on Tuesday. So when we're teaching them stuff, we're going to follow this process called motor learning. And whether you guys know it or not, you've learned motor learning your whole life. You just never realized it. When we are doing a motor task, such as kicking a ball, there are discrete tasks, meaning individual little parts of that we have to work on. There are serial tasks where we chain things together in order to work on it. And then there are continuous tasks that we are going to do to continually get better at it. What can affect overall the ability to learn stuff? Well, the environment, right? If you learn stuff in a closed environment where there are no external distractions, you learn it better. If we had this class right now and we took our class and we had it down on the strip, so I opened up a class right down in the, I forget what the area right outside the Vegas Golden Knights arena, that little like foyer area, and we held class there during a Vegas Golden Knights game. Would you guys learn as much? Probably not. Joe's like, okay, at least you're honest, Joe. Right? You probably wouldn't learn as much because you'd be distracted by all the stuff going on around you, right? There'd be constant distraction. So a closed environment works good, but we don't live in a closed environment. So we may teach a patient in a closed environment, but we eventually have to get them working in an open environment because that's the world. We'll look at doing different variabilities with it, right? Whether we have external stimuli or no external stimuli. So they'll either be present or absent. We'll look at whether we're doing body stable, meaning they're not moving, versus body transport, where they are moving. Are they manipulating objects? I love doing this with a patient where I'll tell them, okay, I want you to walk back and forth 10 times. They can do that, easy. And then I give them a ball and tell them, I want you to throw the ball back and forth while you're walking. And all of a sudden, while they're doing this, now they're weaving in and out with the ball. Because it's a lot harder to do multiple tasks, right? You've heard the old phrase, you can't chew bubble gum and walk at the same time, right? I do this because I've got a lot of ADHD, and keeping my hands moving keeps me on task, and I'm not getting distracted by squirrels all around me. But manipulation of objects is there, right? When we first start teaching somebody to kick stuff, a ball, we may not start with the object present. We may start with the basics of it. So there are three main stages of motor learning. There's a cognitive, associative, and autonomous stage. The cognitive stage is where you have to think about everything you do. I will always take this back to the martial arts for myself. When I was learning the martial arts and I had to learn a new kata or a new form, when I was doing that, I had to think hard through every single one of those forms and every single thing I've done when I was doing them. And usually by the end of class, I was as much mentally exhausted as I was physically exhausted, right? As I got better at it, I started associating or linking one form with another. Oh, what I did in that one, I'm doing in this one. Makes sense now. I didn't have to think about them as much. And then I got to the autonomic stage where I could do it without thinking, right? And now somebody may throw a punch at me and I don't even think, and I can block it without thinking because it's become automatic at that point. Same idea happens for patients, right? We're going to teach them how to sit to stand. And you're going to say, okay, so, nose over toes. Okay, nose over toes. Feel that butt lift up in the back. Push up through the legs. They're going to have to think through every one of those steps in the cognitive stage. And then they're going to get in the associative stage. They're going to be saying stuff like, oh, like when I get up from bed. That's when you know they're starting to get in that associative phase. And then when you tell them to stand up and they just do it, they've gotten that autonomic stage. That's the process. You guys are going through that right now. You guys are in the cognitive stage of learning. You're eventually going to get into the associative phase where you're in your first clinical. And you're starting to associate what you learned in class to what you're doing to the patient. Then by third clinical, you should be pretty well into an autonomic stage where you can actually do the treatment without a ton of cerebral thought. You will get there, I promise you. Pre-practice considerations, right? We look at different things we may have to change. Are we going to practice parts? Or are we going to practice the whole? Are we going to practice just standing up? Are we going to practice standing up and getting a glass of water? How are we going to practice? Are we going to practice in short blocks? Are we going to do different tasks, randomize the practice? Are we going to do different tasks but block those tasks together so we do a random block? We can also do physical versus mental. You will get into the autonomic phase. I promise you, Amanda. I promise you. Right now, what we are doing is a lot of mental practice. We will get into physical practice on Tuesday. We're going to do some exercises, right? But there's a certain amount to do it. Does anyone that ever played sports, did they ever teach you visualization about sports? Like especially, and who's played baseball in here? Right? They tell you to visualize hitting the ball before you actually hit it. Right? Or I love the good old, like the Zig Ziglar and people that do sales. Visualize your sales before you make them. Just think about you driving down that car and owning that yacht. You'll never own the yacht. Just accept it. It's a mental practice, but not a physical. Right? I always think in my brain, I'm eventually going to be a great gaming streamer, but then the physical comes out and I'm like, yeah, no, I'll never be one. Right? So there's physical and there is mental practice. You know, later tonight, I'm participating in a competitive event. I will have to psych myself up for that competitive event and get myself mentally ready, get a little mental practice going on before I physically do it, or I might just lose my mind while I'm doing it. Feedback's important. I give you guys feedback, right? There's a reason why I call some of you out. It's not because I'm making fun of you. It's because I know that some of you like that feedback. You like me knowing that you're still in the room with me, right? There's intrinsic feedback, though. And this is the way I prefer learning on my own. Having my own self tell me what's wrong and what's not right. Your body will tell you that. Augmented, meaning providing additional feedback on top of that intrinsic feedback, right? Where we give external feedback or extrinsic feedback. Knowledge of performance versus knowledge of results. I like to think of this when you're looking at a baseball game, right, or a football game. If you look at the individual line stats, so you look at how, I don't know, David Carr did with the Raiders as the quarterback. That would be more of a performance, how he did. But if his team still lost, the results suck. Right? So knowledge of performance versus knowledge of results can be really important for patients. How you provide that feedback can be important, whether you provide it at the beginning, or you provide it at the end, or you provide it during. Yeah, I think sometimes, I'm going to ask if knowledge of results is a little bit more important than knowledge of performance. I think for some people, I think in my opinion, and again, I'm going to stress this is my opinion, this is not a researched opinion. I think people that are in the cognitive state, the knowledge of performance is more important when they're learning how to do it, right? But once you get to that autonomic phase where you just know how to do it, knowledge of results is really important. You see what I'm kind of saying there? And again, no, you're right. I'm not saying that that's wrong. I'm just saying that it can be varied by the patient and what you're doing with them. But definitely knowledge of results definitely provides. Adherence to exercise is the biggest thing. One of the PTs I know just sent me a message that they typed into they said, this is my note for my patient this morning. Explained AGP to patient for the 20th time this week. That just gets you frustrated, doesn't it? Right? Why don't patients adhere to it? Well, there can be related factors. What if you didn't give them an exercise program they understand? Right? I've had a clinician where I've asked the patient, why aren't you doing your home exercise program? Well, because they gave me the instructions in English and I speak Spanish. Or I can only read Spanish, I can't read English. That's a problem. They're not going to adhere to it then. Factors are really health or impairments. Maybe they just can't do the stuff you want them to do. I go by the golden rule that I usually don't give patients more than 3 or 4 exercises for their home exercise program. Why do I do that? Because most of my patients are going to be sick. I'm not working with somebody like Joe that's, a beast. If Joe's my patient, I might give him more. But most of my patients are kind of not exactly always cognitively there because I work with neuro patients. And if I give them 20 exercises, they're going to do none of them. If I give them 3 to 4, they'll probably do most of them. And then I need to provide them that feedback, right? The knowledge of results, how that affects them. And then program-related variables. Just what do they want to do? If you're giving them exercises so they can run and they're never going to run, they're never going to do it. There are all kinds of strategies to foster adherence. I love using kids to foster my adherence of HEPs. I love when mom brings her little, mom or dad brings their little like 8-year-old son with them to therapy. And I say to mom, are you doing your home exercise program? And mom's like, yep, I'm doing it. And the kid's like, no, you didn't. You told me to tell you if she didn't do it. Right? Yeah, exactly. Like, and mom's like, well, you know, I did it that one time when you weren't paying attention. Use my little spies, right? But even that, you can get them to foster, throw the kid away. But you know what I find is if I get the kid involved in their exercises, the parents do their exercises. So if I teach the kid the same exercises and they do them together, there's some fun there. Right? Somebody that have parents or somebody that have kids can understand that. You know, or if I have a grandparent, a lot of times I'll try to get the grandkids to come in along with it and do the exercises with them. Or make it something interesting, right? If I've got a guy that likes to do bird watching, I'll integrate my exercise program into his bird watching. When we talk about health and wellness, health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. So I'm going to use myself as an example here. I consider myself healthy, despite the fact that I have multiple cardiac conditions and stuff like that. I still have diseases, but overall I'm a healthy person because my mental state's there. I can do most of the stuff I need to do. And I have my social interaction with you guys, and that's all the social interaction I need. Right? So it doesn't mean that I don't have a disease, right? Because I do. I have cardiovascular disease. But my health is still there. I still have my health. Wellness is a state that incorporates all facets of dimensions of physical, emotional health, spirituality, and social connectivity. Right? So you have to have all of that to be well. Health literacy is the ability to provide information so they understand what they need to do to make appropriate health decisions. What we do is health promotion, right? An effort to allow individuals to get better. And then public health is the practice of trying to help people in the community. We're going to talk a second about that. Health-related quality of life is measuring their actual quality of life in the countries or in the states or in the cities. Right, we did that right now with COVID, right? We were always measuring what the infection rates were versus the positivity rates and stuff like that. That was a health-related quality of life measurement. And well-being is just somebody perceiving that they're living their best life. Could you be overall in healthy well-being and not be a healthy individual? I don't know. This is one that I struggle with. You know, if you're not a healthy individual, do you have full well-being? I don't know.
Is it just because you kind of just accept that you can't do certain things so you're mentally well?
That could be, yeah. I mean, I accept that I can't transfer heavy patients anymore, but I still can work with kids, maybe. I don't know. It's interesting, though, when you think about it. My main thing is we used to not consider the mental health of patients, but we now have to, right? Especially in our day and age where we're in a high production, you know, fast-paced, everyone's working 2 to 3 jobs. The mental health of our country is kind of in the toilet. And if our mental health's in the toilet, then the rest of our physical health is going to go along with it. Right? So we have to be thinking about all of that when we're working with patients. Chronic disease is probably the number one conditions that relate to mortality, right? So a lot of conditions lead to patients dying. Cardiovascular disease, cancer, chronic respiratory disease, diabetes. We're going to find that something like PASC, post-acute SARS-CoV syndrome, is going to lead to a lot of patients dying earlier than they should. Right? There may be people that, you know, I love to hear the phrase that, well, you know, 99% of the people that get COVID get better. I've gotten better, but I'm not 100% better. No. Right? It affected my heart. It affected my lungs. And there are still days where I wake up and I'm just absolutely wiped out and I don't feel like doing anything. I had a little bit of that this morning when I woke up, right? And it's not just being tired and lazy. It's just I literally could not get my batteries charged and moving this morning. So I think long-term, we're going to find COVID's affecting our mortality in this country and actually the world quite a bit. Chronic conditions that related to behavior will affect us, right? If I'm constantly only drinking soda, which is bad of me, it can affect my health as well. Health costs due to risky behavior. You feel more exhausted too from, yeah, exactly, right? And the simple stuff you do exhausts you way more than it used to. Same way. I go to the gym, I find myself a lot more tired than I did before. What category of people, you know, if you had to classify age and gender, what category of people takes the most risky behavior?
Young males.
Males, good. What age range? 18 to 25 is usually what we classify as the most risky behavior. Honestly, so men 18 to 25. And if you look at car insurance rates, guess what you find about men that are 18 to 25 paying car insurance rates? They're usually what?
Expensive.
They're expensive. Yeah, right? Ironically enough, you know how a man can lower his car insurance rate at those times? Get married. For some reason, they think as soon as you get married, you stop taking risks. But I question that. Say you might take more risks, but what do I know? I wasn't married during that time period at all. Investments in prevention in this country, we really should be investing more in prevention, right? We should be looking at more of health and wellness and health promotion, and we're not doing enough of that. Wellness, we have all these performance models out there, the 6 dimensions of health, the perceived wellness survey, the model for healthy living. But interestingly enough, about 1996, we came up with this idea of Healthy People 2020. And we said that we're going to develop this. It started in 79. I learned about it in like 96. Started this idea that in 1979, we're going to get our country healthy and get us reduce overall rates of infection, of cancer, of heart disease, blah, blah, blah. How would you say we did?
Really good.
Yeah, really good, right? We've never had higher rates of heart disease. We've never had higher rates of alcoholism, right? Again, we treat diseases, we don't prevent them in this country, right? You go to the doctor because you're sick, not because you want to get a checkup. Now, some of you may, but for the most part, we mainly go to the doctor because we're sick, right? And that's what we usually don't find problems out until it's too late. So we found out that we had this vision, a society where all people live healthy, long lives. What's happened to our average life expectancy here in the United States? Does anyone know? It's gone down. I don't know, man. We're going the wrong way. Not saying that we're bad, but we're definitely going the wrong way. We had these 4 overarching goals: attain a higher quality of life for free preventable diseases, achieve health equality, and improve the health of all groups, regardless of social or physical environments, and promote a healthy development behavior across all ages of the lifespan. I would say that we failed that miserably. I think we need to look at Healthy People 2020 and go, maybe Healthy People 2030? I don't know. But we focused on these 3 things, and we have this primary, secondary, and tertiary prevention. Primary prevention is preventing a problem. So exercise, 2021, we're a little farther away from that. I didn't think about this, but we thought Healthy People 2020, and then COVID came in 2020. Maybe we caused this. I'm just saying. Anyway. So primary prevention is looking at a activity to prevent something. So we know that exercise prevents obesity, right? We know this. It is known. So if we exercise, we can help prevent obesity. If we eat right, we can help prevent obesity. If we prevent obesity, we can prevent heart disease. Kind of a cascading effect. That is a primary prevention. A secondary prevention would be decreasing the duration and severity of the disease. So now, because you have obesity, we're going to exercise more to kind of reduce the overall effects of that obesity. And make no mistake, once you become obese, it is really hard not to be an obese person. I'm speaking from experience. Once you've put on weight, once I broke my neck and I got really up, I'm not in the best, I'm still in shape, but I'm not round as a shape, I guess. I'm not as in good a shape as I was in 2011 when I broke my neck. I was in a lot better shape back then. Once I started putting on weight, it's really hard not to have that weight on you, right? And it gets really hard to keep yourself healthy then. So your secondary prevention becomes important. And then tertiary prevention is, well, at this point, you've got the disability, you've got the disease. Now we just have to see how we can decrease it affecting your life. I think in the United States, we live in tertiary prevention. Would you agree with that? We don't want to prevent it. We just want to give you drugs to reduce its effect on you, and then we'll give you a drug to reduce the side effects of those drugs that we give you, and then we'll give you a drug to help you sleep since you can't sleep because those two meds you're on. I don't know. I was reading when I was prepping for this lesson that the average number of medications is now up to 4.2 medications per person in the United States. 4.2. So there are some of you in here going, that's crazy, I'm on none. That means somewhere in the United States, somebody's on 9 meds. So as therapists in health promotion, we can look at promoting health and behavioral change, assessing their wellness, assessing the functions by the physical therapist, right? And then helping use that primary, secondary, and tertiary prevention to improving their life. We do pre-participation screenings. In October, we have what's called Falls Month. Ha, 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 because October is in fall. Where we will actually, and hopefully we can do it this year, where we'll participate with a bunch of the physical therapy clinics in the area, and we'll screen elder people for falls. Basically bring them in and talk to them saying, so how many times have you fallen in the last month? How many times have you fallen in the last 6 months? The number one predictor for a patient falling is previous falls. So tertiary prevention is, I've got the disease, I'm going to try to make it less problematic. So I've got Parkinson's, so tertiary prevention would be taking a medication. Chemo, yep, there we go. I've got obesity, so I'm going to take a fat burner. They don't exist. But when we're looking at these risk factors and we're looking at these changes for patients, we have to understand patients have to be ready to change, right? This is like Dr. Phil's mantra, right? You have to be ready to change. Could you imagine if we had universal health care and mental wellness was taken in account in that universal health care? We'd never have Dr. Phil. Just saying. He wouldn't have his $60 to $80 million a year. And no joke, his contract is like $60 to $80 million a year. Crazy. When we make changes for a couple of different reasons. We may make them for social and cognitive changes, meaning our own life, right? Making changes so that our own life, our own social life, our own mental life helps us. Health belief model, meaning we finally are convinced that getting healthy makes us healthier. And then trans-theoretical is more looking at how faith and spirituality can help us make changes. I like to think about this when I think of something like Alcoholics Anonymous, because Alcoholics Anonymous has a big big component of it being faith, right? I am powerless to make the change. I must give myself up to the powerless and put faith in something above me to give me that power. I had family members that were in Alcoholics Anonymous. That's why I know this. I don't know personally. Faith does play into this, but let me ask you something about that. What about somebody like me that has no faith? I am diehard, I'm almost full atheist at this point. I'm definitely agnostic. If you try to tell me that God is going to change me, and if I do with all this, God's asking me, right? Nihilistic is about where I'm at, yeah. But if you're a therapist and you approach me from the God perspective, is that going to make me want to change? No, right? So you have to learn your patience. right? I wouldn't try to preach myself on you guys and say, well, you know, there is no God, so you might as well change. He's not going to help you. Maybe believe in the system, right? That might be possible, right? Belief in yourself could be too, right? Maybe you are the higher power. I don't know. But just understand that there are different reasons why people make changes, right? Motivation to changes can be different. It can be intrinsic. You want to change. Could be that you're seeing improvements. Have any of you done this? You've gone to the gym and suddenly you walk by the mirror one day and you're like, hey, I like these changes. Or somebody else says, have you been working out? Doesn't that make you feel good? Man, you lost a lot of weight. Yeah, right? And that just encourages you to do it more, doesn't it? That performance motivation goes on. Sometimes we have task motivations, meaning that if we do this, something else will get easier. My patients that are spinal cord injuries are big examples of this. If I have them lifting weights with their arms, transferring out of the wheelchair is a lot easier. So there's a task motivation that goes along with it. Physical therapy guidelines, we'll go through all of these further in the semester, talking about what the guidelines and recommendations are for children, for adults, stuff like that. So we'll come back to this one. Mindfulness. Mindfulness, how would you define mindfulness? This will be the last thing we end on today, I think. How would you define mindfulness? Have any of you heard that term before?
Yeah, I've heard of it before. There's a couple different variations of it, but a lot of it has to do with being really present in what you're doing and not having distractions. So if you're doing like mindful breathing, you're focusing just on your breathing. Mindful eating, you're just focusing on eating. You don't have like the radio on, you're not looking at your phone.
Good, right? Yeah. Mindful studying, right? You're just focused on studying. Yeah, there's a certain amount of focus to it, right? Mindfulness, and you're exactly right. I always heard, when I think of mindfulness, because I go back to, again, everything from me relates back to martial arts and kind of that Eastern medicine style. Mindfulness is being present in whatever you're doing, being generally aware, right? Exactly, right? Being where you are when you're supposed to be, right? Mindful meditation has been shown to do some amazing things, right? Meaning that if you just meditate for, as I think I was reading last night when I was prepping for this, it is one of the studies showed that if a person meditates for about 15 minutes a day where they're only focused on meditation, like the person's blood pressure dropped by 5 millimeters of mercury overall. It is hard. Yeah. Right? The world makes it hard. But think about that. If you knew, kind of falling asleep, if you knew that you, by doing stuff like this, you could make yourself a healthier person. I like the idea of mindful breathing. I'm not so big on the mindful eating because usually eating for me is when I eat and do 50 other things at the same time. That's probably why I don't eat so healthy. Maybe if I did mindful eating, that's not that long in a 24-hour day at all. You're right, Amanda. Maybe if I did mindful eating, I'd probably be a little bit healthier. I don't think that much about my food, right? Where it comes from, what type of stuff it is, you know, especially when we get stuff like, is it healthy, organically sourced? Is it, you know, ethically sourced, stuff like that. I don't know that I think about that a lot. But mindful breathing I do focus on because I still do a lot of my martial arts and stuff like that. And when I focus heavily on my breathing, because since COVID, it's made my breathing harder, right? It's not as easy for me to get as much air in and as much air out. So I focused a lot more on that. The downside to this is, do you think we get a lot of time to focus on this with patients?
No,
No, why?
you have too many patients.
Too many patients. Okay, there's a good one, right? The other thing is it's not reimbursable. Yeah, right, billing. We're all about that billing. We can't bill for a 15-minute of a breathing session with a patient unless you're doing private pay. I know a guy actually that I've met before that's all he does. He runs a mindful physical therapy clinic in Atlanta, working with vagal nerve stimulation and destimulation, and he just does cash pay. That's all he does. Cash, and he lives in like one of the richest areas of Atlanta, so he can get away with that. But if you're billing insurance, you're never going to get that reimbursed, right? On top of that, do patients want to hear that they're going to have to practice to get better? They just want a quick fix, don't they? That's why we take pills. That's why we, why do you think the diet industry is like, so you can go to GNC and there's 50 different thousand pills to make you lose weight. So we're always looking for a quick fix. We don't want to hear that, well, if you portion your meals out and you eat lots of veggies, we don't want to hear that. That's just too much work.
I've actually lost 140 pounds myself.
Mhm.
And people ask me all the time, what'd you do? What's your secret? And all this stuff. And I explain to them, diet, exercise, and blah, blah, blah. And their face just glazes over.
Yep.
Because it's not what they wanted to hear at all. So now I just make it up and I tell them I was watching YouTube and a commercial for like 2 diet pills came on there and I took them.
Love it. Yeah, I mean, I've lost, so when I broke my neck, I was up to about 290 pounds. So I didn't lose as much as you. I've dropped some, but I'm finding that where I'm at now, it's harder to lose weight. Right? And I know that part of it was diet, exercise, blah, blah, blah. But now I'm at a stagnation point where I just don't want to do anymore. It's really what it comes down to. But you're right. Right? You tell people, how did you lose weight? They want to hear, I took this pill and it made me lose weight. They don't want to hear all the work that goes into it, right? I joke about this because I've had some people, I do some, I guess I wouldn't call it physical therapy, but I do some training for some esports people where we work on improving their coordination in esports. And I can't tell you how many, and I'm starting to get some referrals on this, where people will send me, hey, I want you to work with my son on this. And then I get the kid in with me and I'm talking to them and I tell them what they're going to need to do if they want to become, the next great Fortnite gamer or something like that. And it's not just sit down and play Fortnite. There's a lot of work that's going to come into doing fine motor skill work, cognitive hand-eye therapy and stuff like that. And as soon as that happens, I'm just going to be a YouTube streamer. Even being a YouTube streamer is not as easy as it looks, unless you're female. Anyway, so how to develop a wellness program: assess the needs, set goals, and those goals have to be realistic, right? If you want to, Joe's laughing. Just go watch Twitch once and tell me I'm wrong. Set goals. Those goals have to be achievable. They have to be simple. You have to set rewards for those goals, right? You have to develop the objectives, develop the intervention, implement the plan, and evaluate, right? This looks, for those of you, I think Amanda was in the military. Isn't that right, Amanda? You were in the Navy, weren't you? Right? Does this not look like military plan here? It is, right? It is. But this is how you do it. There's a reason why it works in the military. Because this works for pretty much everything. It develops a plan, right? If you want to build a deck, do you need the deck? What are your goals when you need that deck by? What are your objectives? Well, I've got to come up with $44,000 to build my deck now. Develop the intervention, draw it out, implement it, build the deck, and then evaluate your work afterwards. Something simple as that. All right, I'm done blathering. Sorry it took so long. Are there any questions? I'm going to stop recording now so I can start encoding.